Good evening, everyone, and welcome to today's virtual scientific meeting. It's my privilege to welcome our esteemed speaker, Dr. Prasad Sir, medical oncologist from Apollo Proton Cancer Center. And Dr. Prasad Sir is widely respected for his clinical expertise and evidence-based approach in the management of genitourinary malignancies, particularly in prostate cancer. Today, he will be sharing his insights on an important and evolving topic from MHSPC to CRPC. Can we delay the inevitable? No more further delay. I will hand over the session to Dr. Prasad sir. And Dr. over to you, sir.
So thank you so much, Armagam. So this is
Thank you.
quite a new molecule that what we are going to talk about in the next 20 minutes. So we do have a lot of evolution, I would say, in the treatment of prostate cancer. We had just started only with orchidectomy, and now we do have a plethora of hormonal tablets, few chemotherapy, and a lot of new radionuclide therapy which is coming up. And we do have a better understanding of the immunotherapy, the PARP inhibitors, and the role of prostate cancer. So, having all these molecules, we are having a longer survival in patients who are diagnosed with prostate cancer, who are newly diagnosed until they become castrate resistant and they progress over the course of time. So, right now, our aim should be about how to delay the progression. So, how to delay the inevitable. And that is what we are going to look at. So, we know there are different treatment options evolving on a day to day basis in the treatment of prostate cancer. The standard of care for any metastatic hormone sensitive prostate cancer would be ADT, one of the medications, and irrespective of the timing of the metastasis, risk, volume, burden, and co-administration of docetaxel. In fact, in oligometastatic low disease burden, we can still look at a curative option with radiotherapy. So there are many things which are now coming up. As of now, there is no role for intensification with docetaxel alone, as demonstrated by the phase 1 and the RSN's trial. So this is the yearly intensification strategy along with docetaxel, wherein close to about 800 to 1,700 patients were studied in these three studies: Chartered, Stampede, and the Get UG. So overall, we could see that only the Chartered trial and the Stampede trial were able to have proven outcomes, but Get UG did not prove any proven outcomes. So overall, when you are looking at the guidelines on metastatic disease, castration has to be the baseline. And if you do have a adequate life expectancy, we classify further based on their tumor burden, low volume or a high volume. Look for either eligibility for the chemo hormonal therapy, and then we would go ahead with the addition of hormonal therapy, radiation, hormonal therapy with chemotherapy, with any of those double combination. Sometimes upfront triplet therapy also, castration, docetaxel, or castration abiraterone, or docetaxel with darolutamide. So these are the standard treatment options for the patient who we use. So why and who? So we do have certain improvements in the trials wherein high volume disease is found to be more favorable for the use of chemotherapy, whereas low volume disease we don't have a lot of favoring chemotherapy. So exactly when we are looking at a high grade, high volume disease, we are going for chemotherapy. So low volume synchronous or high volume metachronous or synchronous would benefit with the addition of docetaxel. And when we are using the combinations, we are also looking at who would be the better person who would benefit with docetaxel. A systematic review had analyzed that patients who have a T4 disease would definitely benefit by the addition of docetaxel rather than having T1 to T3 disease. So we might need to be very choosy in identifying the right patient who would have a benefit with the treatment. So the standard of care, again, when you're coming as would be ADT. So these are the ones which we had seen so far. So this is the study which had shown to be the only prospective study design to investigate the combination of darolutamide with an ADT along with docetaxel. So 1,306 patients were diagnosed with hormone-sensitive prostate cancer with a good performance status and who are candidate for dual ADT with docetaxel. M1A, M1B versus M1C was stratified and alkaline phosphatase was also evaluated. Patients were randomized either to docetaxel with ADT or docetaxel darolutamide with ADT, and the standard endpoints were all evaluated. Time to castrate-resistant prostate cancer, pain progression, asymptomatic skeletal event-free survival, time to first symptomatic skeletal event, initiation of subsequent antineoplastic therapy, worsening of the physical symptoms, and opioid use and safety. So all these were evaluated in this particular RSNS study. So they included the hormone sensitive. It is not the recurrent M1 or prior exposure to chemotherapy. And we do have the standard arms, which were randomized into 4 groups. As in the pre-trial, we have arm A, which is the standard of care, arm B, which is standard of care with abiraterone with prednisolone, arm C would be only radiation with standard of care, and arm D would be standard of care, abiraterone, prednisolone, and radiotherapy. So November peace trial was amended to follow for the evolving standard of care with docetaxel. Between 2013 to 14, ADT alone, 15 to 17, docetaxel was added, and 17 to 18, mandatory. So we do have a heterogeneous population in this particular group, wherein their patients did have a different group of exposure. 273 had only ADT, 592 had addition of docetaxel, and 308 had addition of docetaxel as a mandatory standard of care. But whereas in RSNs, all the 1,300 patients enrolled received docetaxel versus compared to that of 61% in the phase 1 trial. So now when we compare, which would be the better molecule along with docetaxel? So we do have the phase 1, which has only de novo HSPC, whereas in the RSNs, in the darolutamide arm, we do have both recurrent as well as the de novo group. Overall endpoints of OS was evaluated as well as the radiological progression-free was the additional endpoint in the phase 1 trial. So extent of disease, all these were all planned. When specifically looking at the effect of docetaxel, the difference would be all the patients in the RSNs did have exposure to docetaxel, whereas only about 61% of the patients did have exposure in the phase 1 study design. In the RSNs study, darolutamide with ADT along with docetaxel had significantly reduced the risk of death by 32.5%. Here we could see the curves along with ADT. At the end of 4 years, 63% of the patients were alive compared to that of the 50% patients who were exposed only to ADT with darolutamide. So the 4-year survival had improved from 50% to 63% with the addition of darolutamide. So the validity of the early results, here we could see the curves overlapping beyond about 1.5 years. So this is another lacuna of the study wherein we could see patients overlapping between 2 arms because of the initial exposure. The initial years did have only ADT alone, but with the addition of docetaxel, only then the curves had started to separate. That was the initial timeline wherein we could see patients did have an overlapping graph during the yearly ADT alone exposure, and only when the docetaxel had been added, we could see the curves separating out. Next, coming to the patients with darolutamide arm who stayed on the treatment more than 2 years longer than the treatment. So here we could see darolutamide patients were able to be on the treatment for more than 41 months, whereas those with only docetaxel did have only 16.7 months. The median follow-up at around 43 months. Whereas in the phase 1, we could see abiraterone with ADT, it was only about 34 months. And again, when you're looking at the treatment discontinuation, so more patients were able to continue on the treatment, and treatment discontinuation was hardly additional of 3.5% compared to that of the ADT with docetaxel alone. Whereas when we are looking at abiraterone, probably due to the addition of steroids, which might probably one of the reasons of high sugars or maybe osteoporosis or bone muscle weaknesses, we could see the treatment discontinuation is close to about 17%. So overall, when we are looking at darolutamide, it did not affect the ability to complete all these prescribed 6 cycles of docetaxel. So when we are looking at the synergistic effect of adding up a hormonal therapy along with docetaxel, more patients were able to complete all the 6 cycles. However, a slightly lesser percentage of the patients did complete docetaxel. Again, when we are looking at the adverse events, many patients were not having grade 3 or grade 4 serious adverse events. It's about 63% in abiraterone, and when we add docetaxel ADT with or without radiation, it is about 52%. So more adverse events are seen in patients who underwent abiraterone, especially when we are specifically looking at the docetaxel subgroup. Whereas when we are looking at the RSNs, their attention were more in the darolutamide arm than in the placebo arm compared to that of the other side effects that what we could see. So overall, when we do have a category 1 recommendation in the NCCN guidelines, we could see that patients were given the options of, I think we can come to the thing later. Patients did have the options of both abiraterone and darolutamide, but probably we might need to choose which would be the right category of the patients based on the different population. So again, when the patients with a high disease burden in hormone-sensitive prostate cancer who are chemotherapy fit, who would be the patients who would be recommended triplet therapy of ADT, docetaxel with the androgen receptor inhibitor? So we could see more than about 94% of the patients had, 94% of the panelists have voted in favor of recommending triplet therapy. Synchronous and asynchronous disease, we could see more than about 50% in synchronous and more than about 87% in the metachronous group who would be benefited with triplet therapy. Again, when we are looking at the safety considerations, we do have each kind of treatment coming up with its own complications, but end of the day, we need to choose the right patient for the right treatment at the right time. So when we are looking at the triplet therapy, infusional treatment, chemotherapy toxicity, administration time, and the other hormone-related changes that what we routinely see with the doublet therapy, like pill burden, exacerbation of ADT adverse events, cardiovascular, cognitive, and bone health will be added, but the right patient will be able to get the benefit of a triplet therapy and probably have a longer survival. So though we do have a category 1 recommendation of both PIS1 and the RSNs, wherein we could see that it's not just alone the ADT and docetaxel, addition of the third triplet therapy does have an impact in the overall survival. So an intensification with the third hormonal agent should be considered as a new standard of care in an appropriate patient who is diagnosed with a newly diagnosed hormone-sensitive prostate cancer. Multidisciplinary care is the key to success, and probably choosing the right patient would definitely be helpful in improving the quality of life and improving the survival of that particular patient. So thank you so much. I'll be happy to have the questions.
Thank you very much, Doctor, for that excellent and insightful presentation. We truly appreciate your time to taking and share your expertise and the latest evidence on managing patients from MHSPC to MCRPC. Your practical experience have been extremely valuable. We will now open the floor for questions. Sir, actually, there are 2 questions in the chat box. If you can,
Dr.
please.
Arul had asked for biomarker evaluation. So at least in my practice, I have started sending the NGS panel for a lot of patients. So now that we are moving more towards an personalized treatment, say for example, we had seen patients who are diagnosed with BRCA mutation. And the newer trials like the talazoparib with enzalutamide, they're also coming up. So when we do have a patient who is not willing to have chemotherapy,
Yes.
when we have a patient with BRCA2 mutation, I can still look at using talazoparib if it is many of the medications are going to be available in India also. We have rucaparib, we have olaparib, but the trial was with talazoparib with enzalutamide, but there are many other trials also which are now coming up. So those are the patients whom we can still omit chemotherapy and probably choose personalized treatment based on their genetic mutation. But again, it all depends upon the personalized treatment and what are the medications available. Of course, accessibility, availability, and affordability does matter in the treatment of cancer. I hope I had answered your question, Dr. Arun.
Thank you, sir. And then the other question, sir. One more question is there.
Dr. Sriram had asked for considering the early treatment intensification. Do you think delaying progression to MCRPC is primarily when selecting the right patient? Definitely, yes, sir. See, I mean, at least I had started with when bicalutamide was the only available drug for prostate cancer patients. Nothing else was available. So when the patient had progressed on bicalutamide, we never knew what to be given subsequently, even if the patient was fit enough. We used to send the patient for phosphorus 32 radiotherapy, I mean radionuclide therapy to the nuclear medicine department, or strontium or samarium therapies were given. Nowadays, I don't think you guys, I mean, the newer graduates would have seen only this P32 strontium and samarium only in the textbooks. We no longer go ahead with those radionuclide therapies now. But over the past 22 years, we had completely changed our way of looking prostate cancer treatment. Definitely, when you could make this as a chronic disease, prostate cancer patients can still be converted into a chronic disease by early intensification. It's nothing but taking out all the clones. When we are using the hormone alone therapy, we take the hormone sensitive clones, but those clones who are resistant just stay back and they progress to become hormone resistant or castrate resistant prostate cancer. So those were the situation. But when you are adding up docetaxel, you are taking up both hormone sensitive as well as hormone resistant clones upfront in the first line setting itself. So in that case, we are able to have a good tumor volume reduction. And especially when we are using chemotherapy in a high disease, high grade, high volume disease, the response is also very good. And nowadays we are now integrating upfront PSMA therapy. So there was a recent phase 2 study design which had been published from the Australian group, wherein upfront PSMA therapy along with the docetaxel, along with radionuclide, I mean, along with hormonal therapy had been tested. And that has shown to have improvement in the overall survival, not just by adding docetaxel, but by adding with upfront PSMA therapy also. So future is going to be very more exciting in the treatment of prostate cancer.
Thank you, sir. Thank you very much. As there are no further questions, sir, we would like to sincerely thank you, Dr. Prasad, sir, once again for an outstanding and thought-provoking session. We also thank all the participants for joining us today and for your active participation. We hope today's discussion has provided valuable insights that can be translated into everyday clinical practice. Wishing everyone a wonderful evening. Thank you, doctor, and have a great day. Thank you, sir.
Bye bye. Thank you.
Thank you. Tech team?
Yes, sir.
Yeah, we will go into the meeting.
We can end the meeting, right, sir?
Yeah, we can end the meeting. Yeah.
Okay, sir.